So first, I would like to thank for the opportunity to talk on this platform. So now what we are going to talk on ultrasound-guided lower limb interventions. So ideally, we can see most of the structures under ultrasound and we can inject everywhere. But what I really want to highlight is why we do use ultrasound. First of all, like we all know that we are avoiding radiation. But in addition to that, you can directly see the structure. Like we saw in the previous talks, we don't need to mark points. We can see them and inject them. Then, obviously, if you can see, your confidence is higher because you can even see your injected flowing, which I'll be showing later. Then, especially with the tendon sheaths, you do not want to inject within the tendon because steroid has a weakening effect. So you want your needle to be well placed, not within the tendon and into the tendon sheath. So that can be done with ultrasound, and you can, at the time of procedure, assess the tendon quality as well. Then there are various papers also which quote this, that ultrasound-guided procedures are shorter and you make fewer needle passes. So in our practice, we do it in one go, so just one needle prick, and there are very fewer complications. So these are few of the papers which even highlight this, that how good ultrasound is. Now coming on to the interventions, so covering all the joints, what all we can do is we can do intra-articular injections, we can inject the tendon and bursae, and we can talk about the ligaments. So let's start with intra-articular. So this is again a paper which shows that hip injections intra-articular when done by ultrasound were more convenient and less painful. And there were even patients who had undergone both preferred ultrasound. So this is just simple, that you need to make the patient lie down supine. What you need to focus is the femoral head-neck junction and then just target your needle at that area. So what you can see is that you can see the injected flowing in and you will get a free flow. So it becomes really simple and you're confident that nothing is leaking out anywhere. Then, then with knee joint, you can give suprapatellar knee joint injections. Sometimes while giving the injection, you may feel a needle plucking in. So you can see under ultrasound if you're going into the synovium, or maybe you're hitting the fat pads anterior or posterior. So this will again increase your confidence. In foot, any joint, you can localize it on ultrasound and give the injections like shown here, calcaneo, cuboid, talonavicular. Then moving on to the tendons. So I'm trying to talk about mainly the Achilles tendon over here. So you can analyze the quality of your Achilles tendon, you can assess the neovascularity within the Achilles tendon, and you can focus the retrocalcaneal bursal fluid. So mostly we do PRP injections for Achilles tendon as well. So like in this case, you can see this is the Achilles tendon which was tendinotic, but there was a focal area of undersurface fraying. So while doing a PRP, we could perfectly target that undersurface fraying and inject the part of the PRP mainly over that area which was most affected. Similarly, you can then avoid the tendon and directly go into the retrocalcaneal bursa with confidence in ultrasound because you can see it directly. Then other tendons around the foot and ankle, so you can inject most of the tendons. So this is an example of peroneal tendon sheath injection. So you can see the needle coming in into the peroneal tendon sheath, and your confidence increases when you can see the injected which is surrounding the peroneal tendon sheath. So you're pretty sure that you're not within the tendon and you have injected your material around the tendon. Similarly, this is an example of flexor hallucis longus tendon sheath injection. So there have been articles which quote that for foot and ankle, ultrasound is very accurate. Then with bursa, you can go ahead and inject the pes enserine bursa. So you can again see your needle and the fluid tracking along the pes tendons. Then you can go ahead with the GT bursal injection. So you can see your needle and you can see your injected going into the bursa, which increases your confidence. Then there are paralabral cysts which can be figured out on ultrasound and can be ruptured and fenestrated and injected. Then this is one important thing which I want to highlight and which we have been doing in our practice. So in a patient with mucoid anterior cruciate ligament. So what we see that on initial examination when the patient comes to us, there is a difficulty in bending the knee completely. So there is a pain which is there posteriorly and the patient is not able to completely bend the knee. So in such a case, in collaboration with MR, you can see this hypoechoic area, which is the mucoid femoral site. So this is your femur, this is your tibia, and this is your mucoid ACL part. So what you can do, that you can target that area, you can go into that mucoid ACL, you can fenestrate that area, and you can inject medicines over that. So what we do is that we go into that area, obviously after giving local anesthetic, we do repeated fenestration of that area. So what orthopedicians would be doing for mucoid ACL is that they go and debride that area, which has a ligament weakening effect. But in this case, we did a study. This has no complications. However, what literature I could read and go through is that post-surgery, some patients may even require a ACL reconstruction. So this is a simpler, not an OT-based procedure, just an office-based procedure which you can do to decompress your mucoid ACL. And as results post-operatively, you can see the patient has immediate effects. So they are able to bend the knee very comfortably without pain. So this is something which we even published recently in Skeletal Radiology. And I think this is an interesting thing to treat the mucoid ACL component. Similarly, with respect to ligaments, you can inject for calcific tendinitis, as Dr. Rajas has already highlighted. So this was a case of medial collateral ligament of the knee. There was a big calcification. So when we injected around the calcification, in certain cases, we may even go ahead and do the barbotage like it has been shown already. So what I would like to say in conclusion is that if you know where, when, and how you need to inject, you can definitely go under ultrasound and do that procedure with confidence. But overall, for all the pain management procedures, this is just to give you pain relief and doesn't treat your basic pathology in few cases. So you need to make the patient aware about that as well. Thank you so much.